A very good morning to one and all. I'm Dr. Sridhar Sundaram, and I welcome you all on behalf of the Indian Society of Gastroenterology to this second edition of the ISD Masterclass. So we'll be discussing a case of jaundice with GI bleed today. We have some luminaries with us as panelists to discuss the case. We have Professor V.K. Dixit sir from the Institute of Medical Sciences at DHU, Varanasi. And we have Dr. Abhijit Chaudhary from IILDS Kolkata, and we have Dr. Piyush Ranjan from Sir Gangaram Hospital in New Delhi. So they will be discussing the case with the students. We have a dear friend, Dr. Devesh Yadav, also from DHU, who will be facilitator for today's case. And I'll ask Dr. V.K. Dixit sir to introduce the students and take over.
Okay, thank you very much. On this morning, I invite Dr. Abhijit. After a long time, I am seeing him, good friend of mine, and Dr. Piyush Ranjan, and all our students who have linked up actually. And we have pleasure to introduce our students actually. Those, so one, Dr. Nilesh, just show your face. Dr. Nilesh Rai, he is doing actually his third year DM resident. And he will be presenting the clinical part of the actually case, and Dr. Mayank Bhushan, and he will be presenting the rest of the investigation and other part of the case. So he's also the third year DM resident, and then some of the residents, they are also sitting and just they are listening us. So it's a very good morning to all of you. So we can go ahead with the case. So we can start the case. Yeah, Dr. Sridhar.
You can start sharing the slides, please.
Okay.
I think there are two computers in that room, so if we can.
There is a lot of echo on that end.
Yeah, if you can mute one of the computers.
Okay.
Thank you. Thank you.
Sir, are the slides visible?
Yeah.
Yeah. Good morning, everybody. I, Dr. Nilesh Kumar Rai, will be presenting a case of jaundice with GI bleeding. Coming on to the demography of the patient, my patient Kaushalya Devi, 58 years female, resident of Panchkoshi, Varanasi, Anganwadi teacher, was admitted to us on 24th of October 2021 with the chief complaints of on and off pain in the right upper abdomen for last 10 days, black tarry stools for last 9 days, and yellowish discoloration of eyes and urine for last 3 days. As stated by the patient, she was apparently asymptomatic 10 days back when she had pain in the right upper abdomen, which was acute onset, moderate to severe intensity, decrescendo pattern. It was non-colicky type. It got relieved after 3 to 4 hours.
Not moving.
Nilesh, I think the slides are not moving. If you can just please check that.
Sir, 1 minute. I will be sharing the slide again.
Yeah.
So now the slides are moving.
If you can put it on slide share, please, and then try to move them.
ठीक है चलो
मूव नहीं कर रहा है,
मूव करेगा
अदर्स मूव नहीं कर रहा है
सर। अनेबल एडिटिंग पे करने के बाद फुल स्क्रीन
और लोगों को मूव नहीं कर रहा है।
Now it is moving.
Sir, I don't think it's moving.
सर अनेबल करके सर्च करो।
Okay, no, okay.
No issue.
वहाँ मूव नहीं करेगी। इससे हम लोगों को उसके लिए आ रही है।
Okay.
So now it is moving.
Yeah, it is. Great.
Okay, I will be again presenting the case. A case of jaundice with GI bleeding. Demography of the patient: Kaushalya Devi, 58-year female, resident of Panchkoshi, Varanasi. Anganwadi teacher, was admitted to us on 24th of October 2021 with the chief complaints of on and off pain in the right upper abdomen for last 10 days, black tarry stool for last 9 days, yellowish discoloration of eyes and urine for last 3 days. As stated by the patient, she was apparently asymptomatic 10 days back when she developed pain in the right upper abdomen, which was acute onset, moderate to severe intensity, crescendo decrescendo pattern, non-Kolki type. It got relieved after 3 to 4 hours, but to recur again after 6 to 8 hours. There was no radiation. There was no relation of the pain to the meals. There was no apparent aggravating factor. It got relieved after IV analgesics. It was associated with nausea and few episodes of non-bilious, non-projectile vomiting. It was not associated with any fever, abdominal distension, obstipation. It was not associated with any abdominal trauma or dyspnea or cough. There was history of almost similar character of the pain episodes intermittently for the next 5 to 6 days, followed by the persistent development of persistent pain with the onset of jaundice. Patient also gave history of black tarry, foul-smelling liquid stool sticking to the pan with frequency up to 3 to 4 times per day. It was associated with orthostatic symptoms. There was history of 4 units of blood transfusion before presentation to our hospital. The black tarry stool was not associated with any history of hematemesis, bleeding from any other sites. There was no history of any peptic ulcer disease. There was no history of any NSAID, antiplatelet, anticoagulation medication intake, or any bleeding disorder. There was no history of any similar prior episodes. There was no history of ascites, altered sensorium, or any endoscopic intervention. There was no history of cleared yellow colored stool since then. Patient also gave history of yellow discoloration of eyes and urine for last 3 days with gradual deepening of the jaundice over 2 to 3 days. And this jaundice was associated with persistent pain in the right upper abdomen. It was not associated with any fever, pruritus, or any abdominal lump. There was no history of any alternative medication intake. There was no history of any prodromal symptoms or jaundice in the family members. There was no history of any anorexia, weight loss, early satiety, or features suggestive of gastric outlet obstruction.
Devesh,
Devesh? बंद कर दो।
so we can go to the poll question number 1. Which of the following is a feature of severe UGI bleeding? So the options, Anil, if you can please run the poll. Okay. So as we can see, most of the people, almost 94% have answered correctly. So the answer is B, all of the above. Yeah. Okay. You can go ahead, please.
Yes. Next. So the answer is all of the above. Then coming on to the past history of the patient, there was no history of similar illness in the past. There was no history of any diabetes, hypertension, COPD or CAD. There was no history of any tuberculosis. There was no history of any surgical intervention, blood transfusion, any history of tattooing or high-risk behavior. In the family history, there was no family history of hepatobiliary or GI malignancy. In the personal history, patient is married since 35 years, living in a joint family, post-menopausal, have 7 children, all born by normal vaginal delivery. There was no addiction. Patient used to take mixed diet and is living in a gangetic bed with the medium of cooking is mustard oil. To summarize my case, a 58 years female living in gangetic bed with no previous comorbidities, presented with biliary type of pain in the right upper abdomen for 10 days, associated with significant upper GI bleed for 9 days, and jaundice, possibly cholestatic, for 3 days without any history of abdominal distension, altered sensorium, fever, without any history of abdominal trauma or intervention.
Just you can just off kar lo. So, Dr. Nilesh, now with this history, Shat's history of the pain abdomen and the jaundice and the history of GI bleed, what are the thoughts which come to your mind? What do you think is the most likely you are dealing with?
You can speak.
Sir, as the patient is having biliary type of pain in the right upper abdomen, and there is also history of melena and jaundice, which is possibly cholestatic, I would like to give the possibility of extrahepatic biliary obstruction. Extrahepatic biliary obstruction, the etiology can be both malignant and benign at this point of time. And in the malignant etiology, I would like to keep the possibility of carcinoma gallbladder, followed by the periumbillary carcinoma and cholangiocarcinoma. In the benign possibility, I would like to keep choledocholithiasis and Mirzi syndrome with upper GI bleed and without any cholangitis or ascites.
With benign diseases, how do you explain bleeding, Nilesh?
Sir, it is difficult to difficult to that the benign will prevent with upper GI bleed, but if there is any history of patient taking NSAID, then there can be associated peptic ulcer and that can lead to bleeding. But my possibility for malignant etiology are more as malignant causes prevent more with upper GI bleed as compared to benign causes.
Among the malignancies, you have kept a possibility of cholangiocarcinoma. Do you think that this presentation fits in with cholangiocarcinoma? Cholangiocarcinoma would present more with progressive jaundice.
Sir, as the history of jaundice is very short, it is less likely to be cholangiocarcinoma, but I will keep the possibility at a lower level, sir.
Have you kept any possibility outside the biliary tract? Do you think it can be anything else? Liver disease, peptic ulcer, bleeding, and then jaundice occurring because of something else?
Sir, as the patient was having biliary type of pain, so I have kept the possibility of biliary tract as the main source of the pain.
So, I think when we present and we analyze history, I think we need to be as wide in our thinking in clinical discussions as possible. So why I'm telling this is, when you summarize the case, I think there are two very important pointers which have narrowed down your arena of discussion, which I think you could broad up, and that I think you should. Like one, you mentioned that this is a possibly cholestatic jaundice.
Yes, sir.
Can you tell me why do you think it's a possibly cholestatic jaundice? Because I think we possibly don't have much of a clue to that is there is the patient, you don't give us a history of pruritus, you don't have any other histories to suggest that the patient has clinical cholestasis. So right at this point, that's my pointer. Second is, when you mention you have also mentioned that the patient has a pain which you are inclined to think as biliary type of pain, and now you mention gangetic belt. Again, the entire discussion would narrow down to a very short spectrum, and I think the basic approach to clinical discussion should be to broaden up, as Dr. Piyush has just mentioned, that instead of narrowing down your thought into just bile duct and its ancillaries, it's always good to open up your thinking and to think all the possible areas from which each of these symptoms can originate. So can you again rethink and tell us something more on this, and then we can jointly think over and
Sir,
come to further.
as the pain is not having any relation to meal, so I kept the possibility of peptic ulcer disease is less likely. Then patient is also not complaining of any pancreatic type of pain, and the pain was not having any radiation to the back. So I was not thinking of any pancreatic pathology. That's why.
Nilesh, I will stop you here because how many people of peptic ulcer disease do you get a clear-cut history of foot pain relationship? What I want to tell is absence of foot pain relationship should not take away a diagnosis of acid peptic disease. I mean, that's a theoretical, though not very strongly in this case, but that the patient did not give a foot pain relationship should not take you away from consideration of peptic ulcer disease. Please make other associated things on this. So can you tell why did you think this is possibly cholestatic? What is pointer towards cholestasis in this case? Clinical.
Sir, there is no any hard pointer towards cholestasis except for the biliary type of pain.
So that's cholestasis have got a definite connotation.
Yes,
And
Nilesh, you are,
yeah, Dr. Piyush, go ahead.
sir, I think Nilesh, you are stuck with the issue that jaundice came last in the, if you look at the chronology of symptoms,
Yes,
pain came first.
Yes.
It was followed very closely by GI bleed.
Yes, sir.
And then 3 days only back before this thing, the patient had jaundice.
Yes, sir.
So this is probably something, I mean, cholestasis has got a definite connotation. What do you mean by cholestasis? I mean, the patient basically started with pain, then had GI bleed, followed very shortly by GI bleed, and then followed by jaundice. So this is the chronology of your history.
Yes, sir.
And why both of us are telling this so emphatically is whatever be your end diagnosis, please at the outset don't narrow down your possibilities and don't jump to terminologies which have definite pointers connotation. So cholestasis, clinical cholestasis, at this point you possibly cannot say with that emphasis. The patient definitely have got jaundice, but you don't have any feature from history or examination right now to tell you, I mean, history right now to tell you that the patient have got cholestasis.
Yes.
Okay. So that's what both of us wanted to say. So,
and gangetic belt also I would remove from the summary. It really narrows down your differential diagnosis.
right. Absolutely. Absolutely. Yeah. So, it should be wider, as much wide as possible. So that's always good for you to think. Because final diagnosis, we are really not concerned with. We are concerned with how you approach, analytically.
Yeah.
Okay.
At this point of, on the basis of history, it is very hard to say that the jaundice is cholestatic. So I kept the word possibly cholestatic.
That's fine. But,
Okay.
So the biliary pain I kept.
So if I tell you, Nilesh, that this is hemolytic jaundice, the patient has received a lot of blood transfusion and has developed some hyperbilirubinemia, how would you counter that?
Sir, patient was also having dark, high-colored urine. High-colored urine, that is against the hemolytic jaundice.
Right, that is one point. So, but still,
constitutional symptoms, absence of constitutional symptoms.
Right, that is another very important point, absence of any constitutional symptoms.
Yes, sir. There is no prodromal history, there is no history of any drug intake, there was no history of any jaundice in the family members, and patient was giving history of biliary pain. So I kept the possibility of cholestatic jaundice as my instead of hepatocellular jaundice.
So can you think of any disease, any liver disease, primary parenchymal liver disease, which can have exactly similar symptom, which you are terming as terminology wise, you are putting as biliary pain, but it's seemingly biliary pain and presents with upper abdominal pain, which is crescendo decrescendo variety, and then develops GI bleeding. Can you think of some primary liver disease under these circumstances? Can any liver disease present like this? And the patient is 58 years old.
Nilesh, very important hint for you. Answer quickly.
Hepatocellular carcinoma.
Yes.
Absolutely right.
Okay.
Absolutely right.
Good, very good. So, hepatocellular carcinoma have got different modes of presentation, and we should always keep in mind those. And one of the important things, so if, say, for example, we consider hepatocellular carcinoma, then what could be the possible reasons of the GI bleeding?
Sir, there can be portal vein thrombosis that can lead to varix development. There can be infiltration of the surrounding structures that can lead to GI bleed. Then there can be development of varix that can lead to GI bleed.
Relation, I'm again
because
here
pain, because of the pain, the patient may be taking NSAID that can also cause pain, GI bleed.
The most important cause you possibly did not mention, the
Hemobilia.
most important cause of GI bleeding in a patient of possible hepatocellular carcinoma would definitely be varicose, but varicose not because the patient has developed portal vein thrombosis,
Portal vein
that
thrombosis,
portal vein thrombosis has given rise to, varices. It's not that. It's always because, almost always because hepatocellular carcinoma
It develops in background of cirrhosis.
Develops in the setting of cirrhosis.
Yes.
And these people have got underlying cirrhosis related portal hypertension, varices, and all these which can bleed.
Yes, sir.
Yeah.
The likely commonest cause if we consider hepatocellular carcinoma as one of the possibilities in this case. What can be another important mechanism of hepatocellular carcinoma producing profuse GI bleeding? One, you mentioned that analgesic induced. Any other mechanism?
Uncommon cause presenting with bleeding in the bile duct. Can hepatocellular carcinoma bleed into the bile duct?
Sir, hemobilia can be a cause of
Very good. Very good. That is what sir is asking you.
Yeah. So does hepatocellular carcinoma produce hemobilia?
Yes, sir. It can produce.
So I'm getting tempted to get to know from you. Can you tell us what are the modes of clinical presentation varieties? There are some varieties of clinical presentation which are known in hepatocellular carcinoma. So can you enlighten us on those?
Sir, HCC can prevent in a background of cirrhosis with GI bleed. It can
cirrhotic.
It can prevent paraneoplastic preventation can be there of HCC. Then
it can present acute decompensation of chronic.
It can prevent with acute decompensation of the underlying cirrhosis.
Then cholestatic.
Sir, it can prevent with intrahepatic cholestasis also.
Not intrahepatic only, it can present with
extrahepatic and
cholestasis.
Yes.
So cholestatic presentation is a very important mode of presentation, and features with decompensation and all these that you mentioned. So it comes in one of the discussions, important discussions of this patient. Any other liver disease you can think of? Say, for example, the patient, I agree with you for right now that the patient has got biliary pain and the patient have got a GI bleeding, but I'm not inclined to believe that this is a extrahepatic biliary disease, or there is primary parenchymal liver disease. Can you extend your imagination further to think of some other primary liver disease which can still produce pain, GI bleeding, but the disease is primary liver disease?
So liver abscess could be presented with hemobilia and abdominal pain, hepatomegaly.
But not this amount of profuse bleeding that warrants that much blood transfusion is distinctly unusual in liver abscess. While it's a theoretical possibility, anything else?
Hereditary hemorrhagic telangiectasia, sir. Rupture of
tumors.
Again, more common, something developmental disease, but but it's not hereditary hemorrhagic telangiectasia. Can you think of a disease, liver disease, which involves multiple areas within the developmental system called bud, where the bud develops?
Polycystic liver disease.
Pardon?
Polycystic liver disease, sir.
Somebody out here has mentioned, provided a clue called choledochal cyst. you know,
Cystic disease of the liver.
known political cyst possibly is not going to be. Can you enlarge this further? Liver disease, biliary disease, portal hypertension. Have you heard the thing called von Mayenburg complexes, ductal plate malformation, and all this?
Yes, sir.
What
Yes, sir.
happened in those? When you get intrahepatic stones, what are the conditions in which you get intrahepatic stones?
Recurrent pyogenic cholangitis.
So that's one. So, I mean, RPC, and what are the RPC-like pictures that are associated developmentally? And can that have GI bleeding associated also by some mechanism? Yeah, somebody has mentioned congenital hepatic fibrosis. So if we, knit together all the small beads into a necklace, like you have got intrahepatic stones, intrahepatic dilated system, congenital hepatic fibrosis like picture, and you have got biliary disease all together. So what is this called? Entire thing. Ductal plate malformation, have you heard of?
Yes, sir.
So उसमें क्या क्या होता है? सोचिए, this is the charm of clinical discussion. That's why we are, whatever be the end diagnosis, we are least concerned. We have to be clinical only. And hepatology or gastroenterology is as objective as neurology. If you put together all your things together in your hand. So you now have got a upper abdominal pain, biliary or significant upper abdominal pain, significant GI bleeding, and subsequent development of jaundice. So what are all the possibilities? So one is primary disease, we consider HCC. Second, we consider, ductal plate malformation. And,
Yes.
and can we consider any other liver disease? Primary liver disease.
Sir, intrahepatic cholangiocarcinoma, can we consider it?
Intrahepatic cholangiocarcinoma. How common is significant GI bleeding in intrahepatic cholangiocarcinoma? It's not common.
Okay, sir.
It's usually not that expressive emergent presentation.
Yes.
Intrahepatic cholangiocarcinoma. It presents more with
Mass and pain.
yeah. So now let's,
Nilesh, what if I say that
Yeah.
if I say that this patient has got cirrhosis, is having biliary colic,
Right.
and then has developed variceal bleed? How do you react to this? What would be your thoughts on this? Very simple.
right, absolutely.
Sir, there can be a possibility that patient is having biliary pain and with
You should have thought of this. Congenital hepatic fibrosis, again, one of very important causes of bleeding in early childhood. What are the different presentations? There are different clinical presentations of congenital hepatic fibrosis. Your patient is 58-year-old. Does it fit in?
sir, age is against the against that.
So what is the usual age of presentation of congenital hepatic fibrosis?
First decade.
No,
Not really.
second decade. It's usually 10 to 15 years.
Okay.
Am I right, sir?
Yes, absolutely.
Yeah.
So, your job would be to expand your set of possibilities and then rule in and rule out. That should be the approach. So now we have got three hepatic disease possibilities before you with points favor, points against. So one is HCC, the other, as Dr. Piyush just mentioned, as cirrhosis along with stones and GI bleeding, and the third is with points for and against ductal plate malformation. Now, what can be the non-hepatic conditions with this? Non-hepatic means non-parenchymal liver disease conditions with this possibility, which you
extrahepatic biliary obstruction, which I kept.
Extrahepatic biliary obstruction, and then let's come to your
malignant etiology in the form of CAGB, periampullary, and cholangiocarcinoma.
Why not benign? So now again the question comes.
The GI bleed is not much common in benign condition. It is more common in malignant. The GI bleed is more common in malignant condition as compared to benign conditions. of
That's
extrahepatic
what-
biliary obstruction.
But the history is very short.
Yes,
Short
sir.
duration of illness. 10 days history only and the first presentation.
That's why I kept the benign possibility also, sir.
So
And-
then
and-
again,
Yeah.
in that case, you will have to find some other cause for it. Maybe NSAID-induced ulcers. A patient who is having biliary colic, NSAID-induced ulcers.
Yes, sir.
It would be. I mean, that is what sir mentioned right in the beginning, that you cannot narrow down by beginning with only extrahepatic biliary obstruction. You have to keep a very broad base, at least at the end of the history, and
Yes.
then see how do your findings match up in the clinical examination.
Yeah.
Yes.
So now we can go ahead with the examination part, sir.
Yeah, one final question. Can the entire thing be
Hmm.
pancreatic disease only? Can you think of a
Sir-
pancreatic disease?
Sir,
Because these are all the features. This is so broad and you need to broaden up. If it
Sir,
is
there-
no, tell us no.
sir, there was no history of any pancreatic pain or any history of
Type of pain.
diabetes.
Okay.
That's why I don't kept the pancreatic disease as the differential.
So what are the ways in which chronic pancreatitis, it would be important. Chronic pancreatitis produce biliary obstruction.
Yes,
Is
sir.
it
Chronic pancreatitis can lead to distal CBD fracture.
right?
That
Right.
can lead to extrahepatic biliary obstruction.
Yeah, you don't want to think that as one of the possibilities right
Sir,
now.
there-
Want to close?
In this short history of only 10 days, and patient was not having any pain in the past, and that pain was not of pancreatic type, and there was no history of any diabetes. So chronic pancreatitis is less likely, sir.
Sir, if the nature of pain is was suggestive of acute pancreatic type of pain, then we can think of acute pancreatitis with CBD narrowing due to pancreatic head edema and hemosuccus pancreaticus, cause of acute upper GI bleed. But the nature of pain is not of pancreatic type, so we kept we excluded the possibility of acute pancreatitis due to that.
Okay. So finally, before we go to further discussion,
Physical, yeah.
yeah, maybe you could summarize the possibilities we have enunciated till now. 1, 2, 3, 4, 5. Liver disease, bile duct disease, and obviously pancreatic disease we have not considered.
Sir, in the liver
Okay.
disease, the HCC can be possibility. And then ductal plate abnormality, and then congenital hepatic fibrosis prevent in the second decade, but
I think in terms of commonality, as Dr. Piyush had mentioned, and also other pointers, your second possibility in liver disease should be cirrhosis with
Yes.
varicose bleed.
and yeah, and third is ductal plate, and
Ductal plate. In the
bile duct you consider
Pardon, sir.
pardon?
biliary, you considered what all?
In the biliary, sir, extrahepatic biliary obstruction due to malignant causes in the form of CAGB, periampullary cholangiocarcinoma, and in the benign cause, the choledocholithiasis and Mersey syndrome.
Okay, so let's go further.
Yeah, examination part. Yes.
So the poll question.
Hello. So
Hi.
now the poll question 2. All are differentiating features of extrahepatic cholestasis from intrahepatic cholestasis except. So
So majority they are right.
majority have answered correctly that pruritus may be present in both intrahepatic and extrahepatic cholestasis. 60% have answered rightly that pruritus is not a differentiating feature for intrahepatic and extrahepatic cholestasis.
Okay. So let's go to the examination part.
Yes, sir.
Yes.
On general examination, patient was conscious, oriented to time, place, person with a BMI of 20.8 kilogram per meter square. Vitals were pulse of 88 per minute, regular. BP was 110 by 60 mm. Hg in right arm supine position. Patient was afebrile. The pulse, the respiratory rate was 14 per minute. FPO2 was 97% on room air. Pallor was present. Scleral icterus was present. Cyanosis, clubbing, lymphadenopathy. Pedal edema was absent. JP was not raised. Left supraclavicular lymph node was not palpable, and there was no scar marks.
Yeah.
Then in the systemic examination, on perabdominal examination, on inspection, there was fullness seen in the right hypochondrium. Umbilicus was central and inverted. There was no scar marks, venous prominence, visible pulsation, peristalsis. Hernial sites was free. On palpation, local temperature was not raised. Tenderness present in the right hypochondrium and epigastric region. Liver was palpable 2 cm below the right costal margin in the mid-clavicular line. Tender, firm in consistency, regular margin, smooth surface. Left lobe was not palpable. And a cystic globular lump palpable below the lower margin of the liver of size 4 into 3 cm and tender. Spleen was not palpable. On percussion, liver span was 16 cm, tender on percussion. There was no evidence of any free fluid in the abdomen. On auscultation, bowel sounds was normal. On rectal examination, finger was stained with black colored stool. And the examination of other system was within normal limit. The respiratory system and the CVS and CNS all were within normal limit.
Okay, so did the examination help you in further narrowing down your possibility? So could
Sir?
you tell what are the differential after the examination?
Yes, sir.
What do you think? What are the possibility?
Sir,
Because which you thought earlier, now they have been narrowed down.
Yes,
like
sir.
for example, you thought earlier the hepatocellular carcinoma. Now,
Yes,
will you have to still consider in a palpable gallbladder?
no, sir. I would.
It's less likely. So now, what do you think actually after the examination?
Sir, after the exam, as having palpable gallbladder,
Yes.
so I would that goes in favor of the extrahepatic biliary obstruction, and I would like to keep the possibility of malignant etiology as periampullary carcinoma, distal cholangiocarcinoma, and I would like to keep the CAGB of the neck at the last possibility. And regarding the benign causes, since the gallbladder is palpable, the choledocholithiasis is out of the question, and Mirzi syndrome can still be a possibility. It can prevent with palpable gallbladder.
For the benefit of everybody, can you spell out the complete Courvoisier's law, Nilesh?
Sir,
yes.
Courvoisier's law states that in a patient of obstructive jaundice, if the GB is palpable, it is not due to stone disease.
Right. So this is a negative statement.
Yes, sir.
So with the presence of smooth globular, how do you say that this is gallbladder? Why do you say that this is a gallbladder lump?
Sir, it is present below the plane of the liver, and I would not able to get above it. It's because of the globular consistency and the location. It's most probably gallbladder, sir.
Mobility
okay, if you
find, sorry, sir.
No, but let's suppose if you find this type of lump actually in other patient also, then what are the other different category you can think of? One you said is palpable gallbladder. Anything else which come to your mind? If I say it is not gallbladder, then can you think of other things also which can mimic like this?
Sir, hepatic mass can also prevent like this, but it was felt separately from the liver, sir.
And what about radial slope?
Pardon, sir?
Radial slope.
Sir.
Okay. Okay, go ahead, sir. Please.
Yeah,
Dr. Ranjan, please go ahead. Yeah, Dr. Abhijit, yes.
So what do you, I mean, when you see a lump, you should be in a habit of describing it completely, whether it is intraperitoneal, extraperitoneal, what are the points for and against for an intraperitoneal lump, extraperitoneal lump, various features, and then where you place this lump.
Yes, sir.
with this description of the lump that you told us, are you serious about considering a diagnosis of CAGB? And if you are, then what is your physical pointer to that? That's my, I mean, let's start from below, your third possibility of CAGB.
CAGB present usually with a hard lump, and
Right.
here the lump was cystic consistency.
Yeah.
That goes in against CAGB. But if there is growth in the neck of the gallbladder, then there can be cystic gallbladder palpable in a patient of CAGB, sir.
So again, Nilesh, for everybody's understanding, could you just present what are the ways of presentation of CAGB? What are the different ways in which CAGB presents? Clinical ways.
Yes,
There
sir.
are ways, you know, syndromic ways of presentation of CAGB, which are pretty well known.
Sir, it can prevent with biliary pain. It can prevent biliary obstruction. It can prevent with cholangitis.
So it can present just like an acute cholecystitis picture.
Yes, sir.
Okay. It can present with biliary obstruction.
Biliary obstruction. It can prevent with mass in the right upper abdomen. It can prevent with cholangitis.
What is the distribution? What is the distribution of CAGB within neck,
Sir,
body, fundus? What are the percentages?
The most common site is the fundus 60%, then the body 30%, and neck part is involved less in 10% cases. Fundus, body, then neck 60, 30, and 10.
So your presentation will also vary depending on the site of the initial growth.
Yes,
and
sir.
presence of the metastasis. Then you can have lymph nodes which can be causing compression. So this is the way it goes. And
Yes.
depending on the gastric outlet obstruction, the compromise of the gastric outlet lumen.
Yes, sir.
This is the way.
It can involve the duodenum also. Duodenal infiltration can be there, which can prevent with upper GI bleed.
Right.
Right. So what proportion of patients with CAGB have duodenal outlet obstruction?
The duodenal obstruction, sir, it is less
Yes.
than 10%, sir. It's very less. I would say 5%, around 5 to 10%.
No, it is higher.
Sir, in the Indian series of SGPGI, it is.
Okay, so do you seriously consider CAGB to be one of the important diagnoses, or you wanted to, mention this just to complete the diagnosis?
Sir, just to complete the diagnosis, I have kept it.
Okay.
They were less likely possible.
Now come to your first possibility of periampullary CA. So,
yes.
Is there any, what are the pointers in favor of periampullary CA, and what are the pointers which are relatively odd for periampullary CA?
Points favoring periampullary is the history of GI bleed, which is there in the periampullary, and the biliary type of pain. That pain is although less in periampullary. The the points against periampullary is the female sex of the patient. The pain is against the periampullary.
Periampullary CA
No.
in males or females?
Yeah.
Sir, it is more common in males, sir.
Yeah,
Yes.
so that's an odd feature.
Odd feature.
Yes.
So
Yes.
delineate the points in favor, points against. You mentioned
Yeah.
that
Yeah.
bleeding is a point in favor of periampullary CA. I agree. But we started the first poll by telling that significant and severe GI bleeding.
Yes, sir.
So is that a common feature of periampullary CA?
No, sir. It is not a common feature.
Not a common feature.
Yes.
So that relatively becomes to me an odd feature. The amount of bleed that this lady had,
yes, sir,
is relatively odd for entertaining a diagnosis of periampullary CA.
Yes, sir.
Okay, while we are not excluding that, so you also mentioned that pain is an unusual feature.
Yes, sir.
But now, can you tell us some mechanism by which a periampullary CA can still have significant pain?
Sir, if patient goes into cholangitis,
no,
then
even commoner than that.
Due to obstruction, what do these patients develop? Biliary obstruction, what do these patients develop?
So there can be associated stone.
Absolutely.
Yes,
right?
you're right.
Associated stone.
So what is
Yes.
the association of stone with each of these biliary malignancies? Can you also tell us?
Yes, sir. Most common association if with the CAGB.
How common?
Sir, CAGB cholelithiasis is prevalent in about 80 to 90%. Sir,
Good. Okay.
association.
That's right. That's right.
Okay. Okay.
And the association of periamp and distal cholangio with cholelithiasis and choledocholithiasis is less common, sir. As
How
per
much?
Yes.
CAGB.
How much? We know less common, but is it 50% or even below that? I mean,
It's below that, sir.
15, 20%, or I'm just dragging you because you need to be very clear, very emphatic in this. So it's 15 to 20%, less than 25%. Okay, but in a given patient that can still be happening.
Yes, sir.
Okay.
Yeah.
So now, so periampullary CA, you mentioned the positive point is GI bleeding.
GI bleeding and
We
sir,
argued that
palpable gallbladder.
significant GI bleeding is not common.
Feature, not a feature.
Yeah.
So that's why, Dr. Nilesh, what you can do now, there are
Yes.
4 components of periampli, right?
Yes, sir.
Duodenum, ampulla, and then lower end of CBD and the pancreas, right? So which part is actually predominant, the symptom will also vary accordingly, right?
Yes, most
So
common.
you can describe like that. So like if you have a ampullary mass, naturally your pain is very less and the significant bleed is also very less, right? But suppose you have some infiltrating tumor from the pancreas with some neovascularization, something like that, you can have significant bleed. The pain will be also very much more, right? So
Yes.
depending on, you can say, depending upon which component is more predominant, the symptom will also vary accordingly, right?
Yes.
Okay, go ahead.
Okay, so your second possibility is distal cholangiocarcinoma.
Distal cholangiocarcinoma.
So how do you explain the bleeding in distal cholangiocarcinoma?
Sir, distal cholangiocarcinoma, there can be bleeding because of the hemophilia.
How common is it? Is it very common or it's not?
Sir,
Common?
it is less common in about 4% to 5%. Yes, sir.
Okay. So what are all the bile duct lesions in which hemophilia occurs, and what are the other causes of hemophilia? Let's think hemophilia in the center. Let's keep hemophilia in the center. So if it is hemophilia, because the patient had significant bleed.
Yes,
So
sir.
if we start off with the significant bleed and we have ruled out, peptic ulcer as one of the causes,
Yes, sir.
then your next possible site of the bleed could be the
Biliary tract.
ampulla. Okay.
Yes, sir.
So blood coming from ampulla can either be from the pancreatic duct or it from the bile duct.
Right.
We considered and excluded that pancreatic disease in this patient we are not seriously considering.
Yes, sir.
Yeah.
Right now we are seriously considering bile duct disease
Bile duct.
because the patient have got GI bleeding along with subsequent development of significant jaundice
Jaundice.
preceded by pain. Okay.
Yes, sir.
So if we concentrate on the bile duct alone, and if we consider significant bleeding to have been caused by hemophilia, bile duct bleeding within the bile duct, then what are the possibilities?
Sir, there can be iatrogenic cause of hemophilia. There can be traumatogenic causes.
Let's come to this patient. Let's come to this.
In this patient, we can consider the neoplastic etiology, which I have mentioned as the cause of hemophilia. The periampullary, the distal cholangio, and the CAGB preventing with hemophilia.
Okay.
Then other causes of biliary tract which can prevent with hemophilia are the portal cavernoma cholangiopathy, or any parasitic infestation, which that can also prevent with hemophilia. Sir.
Can any benign bile duct tumor produce hemophilia? Or no? If you are confident no, then say no. I'm just considering. Can biliary adenoma produce hemophilia? If it is no, it's no.
Sir, malignant etiologies are common causes.
More probably, yeah. So,
okay. So what are the liver diseases that can produce hemophilia? We consider HCC. I'm not, leaving you from the liver because jaundice per se, one should always keep liver in mind. So consider HCC.
Apart from HCC, sir, any percutaneous intervention of the liver can prevent with hemophilia, like in the form of liver aspiration or PTBD or PTC intervention, or any radio frequency ablation of the lesion in the liver, or any transarterial chemoembolization.
Okay.
These are the
So any spontaneous, non-iatrogenic vascular disease produce hemophilia in this region?
from the liver, sir.
Yes, hemophilia from the liver or whatever, bile duct or liver. Any primary non-iatrogenic vascular disease.
Sir, hereditary hemorrhagic telangiectasia.
Okay, what else?
Sir, any vascular malformation in the form of aneurysm.
Right. Can produce hemophilia. Somebody says here, Sushil Bhattad mentioned ruptured hemangioma. How do you respond to this possibility?
Sir, that can
Is that a possibility?
ruptured hemangioma in this case, sir.
Yeah.
Or just to complete the
Hemangioma rupture produces hemophilia more commonly, or it produces hemoperitoneum more commonly?
Sir, hemoperitoneum will be more common.
Yes.
Right.
So you have
Rupture
to
into the peritoneal cavity, not into the biliary tract.
Yes. So intra bile duct bleed is uncommon in hemangioma. They usually bleed within the peritoneal surface.
Peritoneal cavity.
Okay, so good. So one is you mentioned among the vascular diseases that you can still have aneurysms of the. So which artery is around these areas?
Sir, hepatic artery and cystic artery, they are most commonly have aneurysm leading to hemophilia.
Right.
Yeah.
So, and hemophilia. So and of the two, which one do you think more commonly causing hemophilia?
Sir,
Hepatic.
hepatic artery.
Hepatic artery. Yes.
Right hepatic artery.
Okay. So
Okay.
that should always also be, but odd for that would be what? Significant amount of pain preceding and the subsequent jaundice. Alone GI bleeding could have been caused. But can this be an accompaniment of some disease in this region in which hepatic artery is also involved in the inflammatory process, chronic inflammatory process, and you get a reactive aneurysm formation, the way chronic pancreatitis produces splenic artery aneurysm? Can you think around?
Sir, cholecystitis, recurrent episodes.
Recurrent episodes of cholecystitis is usually not
Other
a-
vasculitis like
Polyarteritis
polyarteritis
nodosa.
nodosa can produce the hepatic artery aneurysm, cystic artery aneurysm,
Yes,
and
good.
bleed spontaneously.
Yeah, that's good. That's a good possibility. So it's good that you should always think aloud and God, and then come to possibility. So where do you stand at the end of the discussion of clinical and findings? So do you want to modify your possibilities after this, or you want to stand here where you mentioned? You mentioned about mirices also.
Yes, sir.
So why mirice? Because the liver was, the GB was palpable and the patient had. Do you think mirice can produce that amount of bleed also?
No, sir. It will not prevent that amount of bleed.
Because bleed is the most important life-threatening circumstances in this patient.
Yes, sir.
Yeah.
Okay. So mirices you are not considering. So any benign disease you would like still to consider in this patient, either single disease or two diseases together. आप तो मैलिग्नेंसी के ऊपर ही बैठे हो, ये छोड़ के कुछ आपका इमेजिनेशन एक्सटेंड कर सकते हो?
Can we
Dr. Nilesh?
possibility of portal cavernoma cholangiopathy?
Portal cavernoma cholangiopathy, and then bleed would
See,
be
with CBD stone.
Yes, sir.
Okay.
CBD stone and portal cavernoma cholangiopathy.
portal cavernoma cholangiopathy. Good possibility.
Dr. Nilesh, can you think of biliary ascariasis with the stone
Sir, yes.
disease?
Sir, parasitic infestations can also lead to.
Yeah, that should be also kept really, though
Yes,
it is
yes,
uncommon.
events
Yeah.
that clonorchis.
Dr. Nilesh,
Yes, sir.
will you keep possibility of biliary cyst adenoma?
Biliary cyst adenoma, sir, it will not prevent with that much amount of bleed.
That can be benign also, that can be malignant also.
Anyway, chalo.
Now, how do you plan to, evaluate
Yes.
that
Yeah. So we can go further about the investigation part, right, sir? Okay, go ahead. Next.
Now the Poll question 3, I think. Poll question
Yeah.
3.
Hmm.
Poll question 3 is, what percentage of malignant EHBO presents with upper GI bleed in Indian scenario? Can you run the poll, please? What percentage of malignant EHBO presents with upper GI bleed in Indian scenario? A, 5 to 10%, B, 10 to 20%, C, 20 to 30%, D, less than 1%. The result is 43% have chosen A and 40% B. Just good fight between A and B, but the answer is A, 5 to 10%, and 43%.
That is the most appropriate answer.
Yes. Answer.
Yes, go ahead. Dr. Nilesh, you want to speak?
Devesh sir will take over the learning side.
Achha,
So
Devesh,
there are a few
I think
slides for learning of these residents. The jaundice clinically detectable bilirubin is more than 3 milligram per dl. And if patient is presenting with jaundice, see the urine color. If it is yellow, then it may be hepatocellular jaundice or extrahepatic biliary obstruction, it is obstructive jaundice. If the color is not yellow, it is pale, then it notifies hemolytic jaundice. Next. So jaundice with yellow urine, how to differentiate between hepatocellular jaundice and cholestatic jaundice. So if there is history of prodrome, or there is similar history in family members or in the community, or there is a history of drug intake or herbal supplement or alcohol intake, and or alternative medicine, complementary alternative medicine intake, that favors hepatocellular jaundice or hepatocellular injury. If there is a presence of GI bleed like hematemesis or melena, or patient have ascites or encephalopathy, you will first think of hepatocellular jaundice. In cholestatic jaundice, there will be high colored urine, there will be clay colored or white colored stool, there will be significant pruritus, and patient may present with cholangitis. So these are the soft points differentiating hepatocellular jaundice and cholestatic jaundice. Next. Now, if the patient is presenting with cholestatic jaundice, the cholestasis may be extrahepatic and intrahepatic. So what are the points favoring extrahepatic? So if patient is having significant pain abdomen, like patient having biliary pain or significant pain abdomen, that favors extrahepatic. Lump abdomen also favors extrahepatic cholestasis. And if there is history of any intervention like surgery or endoscopy or any radiological intervention or FNAC, that also favors extrahepatic cholestatic jaundice. History of cholangitis, history of GI bleed, history of ascites, gastric outlet obstruction, and severe weight loss and anorexia also favors extrahepatic biliary obstruction, though weight loss or anorexia can also present in intrahepatic cholestasis also. Prodromal features, similar history in the family or community, history of drug intake or history of complementary alternative medicine intake, prolonged fatigue or pruritus, or critical illness, shock, parental nutrition. These points favors, or history of sepsis favors intrahepatic cholestasis. So these are few points favoring differentiating extrahepatic and intrahepatic. The main points on pain, cholangitis, lump abdomen. These favors extrahepatic cholestatic jaundice.
next.
Once you have seen that it is extrahepatic, then how to differentiate between benign and malignant? So if patient cholangitis can be seen in both benign disease and malignant also, but benign in cholangitis is more common seen in benign diseases, because in malignancy there are almost complete obstruction. So chances of cholangitis is less. Biliary pain and young age of onset or longer history or very short history, these both points favors benign diseases as compared to malignant. Severe weight loss, severe loss of appetite, gastric outlet obstruction, presence of ascites, presence of GI bleed, old age of onset, and change in character of pain favors malignant etiology of the EHBO.
Next.
So now we have some points. GI bleed with jaundice. So GI bleed with jaundice can be seen in that liver disease and EHBO also. So GI bleed with liver disease seen basically in portal hypertension like esophageal or gastric varices, ectopic varices, portal hypertensive gastropathy, gastric antral vascular ectasia. But peptic ulcer disease also can lead to GI bleed in patients of liver disease, and the bleed can also be due to coagulopathy. Next, GI bleed in EHBO. What is the mechanism of GI bleed in EHBO? It can be because of infiltration of malignancy into the GI tract, like carcinoma, gallbladder, direct infiltration into duodenum and antrum, periampuli carcinoma, carcinoma head of pancreas. They can infiltrate into the duodenum. Portal vein or splenic vein thrombosis that can lead to portal hypertension and can bleed from the esophageal or gastric varices. Long standing obstruction with secondary biliary cirrhosis. So if the patient is having long standing biliary obstruction, that can lead to secondary biliary cirrhosis and can lead to portal hypertension related esophageal and gastric variceal bleed. Then patient is having pain and they are taking long-term NSAIDs for pain relief that can cause gastritis or peptic NSAID related ulcer bleed. And lastly, hemophilia can be present in cases of EHBO patients. Now to Dr. Nilesh.
Now, Dr. Mayank will be presenting the investigation part.
To investigate her, first I would like to assess the severity of her upper GI bleed, since she was presented with severe upper GI bleed with transfusion of 4 units of blood. So this slide is showing her hemoglobin on the day of second day of her presentation. Her hemoglobin was 3.9, and she was admitted to us on 24th of October after 4 units of blood transfusion. And I would also like to see TLC count, which is gradually increasing. And on the day of presentation, it was 8,000 and gradually progressed to 22,000. Platelet count was absolutely normal.
So good. Mayank, tell me
Yes,
one
sir.
thing. You have mentioned here hemoglobin.
Yes,
So
sir.
for the severity of the bleeding, okay.
Yes.
So, but are you happy in getting in as hemoglobin as the only guide for management of a significant GI bleeding, or
Sir,
you have
in
some?
the initial phase of upper GI bleed due to hemoconcentration, hemoglobin or hematocrit, hemoglobin could be normal or hematocrit could also be normal. But after resuscitation, giving IV fluids and other measurement, hemoglobin could drop. And sir, as it is seen that with up to 50% of cases of upper GI bleed, TLC count could be raised. And sir, to assess her, sir, first airway breathing circulation ABG should be done.
No, you mean to propose that this 22,000 total count and the progressive increase in total count is all because of an impact of upper GI bleeding as a stress
Sir,
phenomenon?
it could be due to, sir, as in examination we find palpable lump. So
Right.
rising TLC count could be due to cholangitis or ascending cholangitis infection in biliary tree.
Okay, and you don't have any history of fever in these patients,
Yes,
so
sir.
make you unwise, or that can still happen?
Sir, patients, considering age of the patient, she is a 58-year-old female. So, sir, fever, every cholangitis case could not present with high-grade fever.
So how
So,
many of them present with fever? How many don't present?
sir, up to, sir, 20 to 30% of elderly patient cannot present with fever and acute cholangitis, but
No, what
can
is that?
present
No,
with
no.
cough, rising TLC count, neutrophilia, leftward shift, and
That's
sir,
fine. Let's come to cholangitis symptoms only. We let
90% cholangitis patients will have fever.
fever.
So what are the features of, again, very traditional old days symptoms of fever? You tell us. You have got those triads and pentads. So how many of them have got triads and how many of them have got pentads? In which way? Which proportion? Percentage? That's very important.
Sir, Charcot triads are present in up to 40% of the patient, in cholangitis and pentards in around 30% of cases.
नहीं उससे भी कम है, पेंटेड इतना थोड़ी होता है, दुनिया
Pented is very low.
दम मर जाना था. So ये बताओ, even within those Charcot triad, how many of them will have fever? How many of them will have other features? How many?
In Charcot triad, sir, almost every patient have fever. Up to sir more than 90% of cases have fever, and sir 50 to 60% cases have jaundice, and sir abdominal pains are present in almost every case.
Sir, fever is prevalent in 90%. The pain is prevalent in 80%, and the jaundice is prevalent in 70%. Sir.
Right.
That's better.
She is fair and Mayank is was you know bit jittery. So can you have fluctuating jaundice also in cholangitis, or you don't have?
In periampullary carcinoma, sir, there can be fluctuating jaundice.
I'd say cholangitis is a cause of fluctuating jaundice.
Jaundice.
Even if you don't have, because you have got inflammation, the biliary tree is inflamed, you have got edema, and that's producing a dynamic component to the obstruction, which may get relieved as you treat cholangitis, and your excretion of bilirubin might improve. So cholangitis alone in all the conditions can cause fluctuation. Fluctuating सुनने से ही हमारा दिमाग में periampullary carcinoma आ जाए, ये सब समय ठीक नहीं है.
Yes, sir.
Yes, sir.
So, any variety of cholangitis can cause some amount of fluctuation. It will not be dramatic, but it will have some amount of fluctuation. And this total count, when the total count is elevated with a person with icterus, you are and with all the features, you are obviously concerned that the patient might be having an infection. और डीसी में भी आपका क्या है, 92 है, 86 है, 87 है. So you have got good response.
Yes, sir. Coming on the next one.
Next one.
In sir biochemistry, her on the day of presentation, her hemoglobin total bilirubin was 1.6, and when she came to us, her hemoglobin was 6 with total bilirubin was 4. And SGOT, SGPT shows hepatocellular pattern, and alkaline phosphatase with upper limit of normal value is 310, which is almost more than 2 times of upper limit of normal, suggestive of cholestasis. So hence it is most likely, sir, both hepatocellular and cholestatic type pattern of injury. And her urea creatinine value is almost normal. Sodium potassium is also normal. Viral marker negative. INR was 1.44, and carcinoembryonic antigen was 3.55 with upper limit of normal is 5 nanogram per ml, and CA19-9 is 6.0 with upper limit of normal is 37 international unit.
So your bilirubin and enzymes,
yes, sir,
have improved from 24 to 26.
Yes, sir.
Significantly improved.
Yes, sir.
So,
sir, after intervention, we progress to next slide. We did, sir, ERCP and biliary stenting afterwards. This one.
And that improved, these two improved after that.
Yes, sir.
So there was something that happened on 25th.
Yes, sir.
So if you don't know, Mayank does not know what has happened to this individual. He is blindfolded.
Yes, sir.
So can you now imagine and tell us, yeah, clinical discussion mein, you should close your eyes and start thinking, kya ho sakta hai?
Yes,
Kya
sir.
ho sakta hai?
As you told previously, sir, acute cholangitis could be possibility, or passed up biliary stone are the possibility in this scenario.
तो आप ये कैसे एक्सप्लेन करोगे, इसका एंजाइम ओटीपीटी इतना एलिवेटेड है इन ए पेशेंट हु स्टिल यू डिड एन ईआरसीपी एंड यू आर पुलिंग अस ऑल टू द possibility of having some CBD disease. So how can we explain these liver enzymes to be that elevated?
Sir, as in previous slide, I have shown her hemoglobin was 3.9. So one possibility is that she must have went into hemorrhagic shock. So this could be due to ischemic hepatitis. And other possibilities are acute cholangitis is also there. And acute cholangitis, AST, ALT level could rise up to, sir, in thousands also. Acute biliary tract obstruction.
Okay, so you consider hemorrhagic Ischemic hepatitis.
Hemorrhage, ischemic hepatitis, and due to sir CBD obstruction.
Ischemic hepatitis is not a good possibility, Nilesh.
Yes.
There is a different pattern of rise and fall of SGOT,
Yeah,
SGPT.
yeah. Yes, yes.
It will be more than thousands.
Yeah,
It
more than
normalizes very
2,000,
quickly.
3,000 like that. Yes.
Normalizes very quickly.
Absolutely.
Yes.
Dr.
And
Mayank,
bilirubin does not rise that much in ischemic hepatitis.
Ischemic hepatitis is not a good possibility. ये मान लो।
Yeah.
So some biliary obstruction which has resolved spontaneously or by some intervention which you are still to mention.
Okay. Next one. Next.
Sir, UAG abdomen, which was done on 15th of
Nilesh, at this point of time, can you stop? I mean, can you give us an idea that after having these, how do you further plan? The person is having bleeding, the person is having jaundice. So what would be your sequence of investigations which you would like to do?
Sir, first I would like to do as ultrasound is readily available, easily available, can be available bedside. So first investigation to rule out or cut down the list of our differential diagnosis is ultrasound abdomen. So with the use of ultrasound abdomen, we can rule out, sir, any hepatic space occupying lesion like HCC and pancreaticobiliary malignancy, cholelithiasis, choledocholithiasis, portal hypertension, and many more. So, sir, first
This patient was bleeding. This patient was bleeding. So before, obviously, ultrasound is one thing. So when would you do an upper GI endoscopy for her? How urgent?
Yes, sir. After stabilizing patient, if patient is hemodynamically stable, her blood pressure is stable without but blood pressure is stable, then we can go for, sir, upper GI endoscopy. Urgent emergency upper GI endoscopy is indicated in such kind of patient within, sir, 12 to 24 hours after stabilization.
तो इनको आप 15th का पेशेंट अपने पास आया था.
Sir,
So,
actually, sir, she was presented to an different hospital with upper GI bleed, where she was transfused. She came to, sir, our hospital on 24th of October. On the same day, we did her upper GI endoscopy, sir.
okay, good. So
Right.
All these investigation, like
upper GI endoscopy is more necessary, more emergent necessary than ultrasonography, isn't it?
Yes, sir.
Right.
Okay.
So go ahead. What were the findings?
sir, on ultrasound abdomen, liver was normal, 11.14 centimeter in size, shows normal ecotexture. Intrahepatic biliary radicals not dilated. Distended gallbladder shows homogeneous hypoechoic lesion in the lumen of gallbladder of approximate size of 40 by 37 mm, which could be with possibility of mass. CBD was normal in size. Portal vein was normal. No ascites or lymphadenopathy.
तो ये देखने का बाद we all vote in favor of Nilesh Kumar, or we still wait and look for something more? Do you think CAGB is a very high possibility right now, or you want to think something more?
Sir, ultrasound abdomen suggests of homogeneous hypoechoic lesion. So, sir, generally, sir, carcinoma gallbladder is, due to extensive fibrosis and mass effect, it is, sir, hyperechoic. So, sir, it could be, sir, blood clot or mass, both possibilities are there.
Nilesh, the problem here is that intrahepatic biliary radicals are normal. The common bile duct is not.
Yes, sir.
So that is the problem with this ultrasound. I mean, gallbladder, yes, could be a mass, needs to be evaluated further. But
So, sir, with this ultrasound, sir.
But this ultrasound is of 15. This was done from outside. Move
Yeah.
ahead, I think. The
Sir,
patient came to you on 24th. This ultrasound is of 15th. So that
Yes.
is probably the answer. That probably at that time, bile duct was not dilated.
And sir, patient was taking follow on the basis of this ultrasound abdomen. Patient was referred to surgical oncology department of our hospital, from where, sir, our other investigation were done. This is a poll question.
So poll question number 4. Kindly run the poll, please. All are specific features of obstructive jaundice on ultrasound abdomen except dilated IHBR, CBD stones, hepatomegaly, and cholangitic abscess. Which one is not found in, especially in obstructive jaundice? Very simple question, I think. I will expect 99% to give the correct answer. So, yes, share results. 89% have shared hepatomegaly. So hepatomegaly is the correct answer. It is not a specific feature for obstructive jaundice on ultrasound. 89% people have given the answer correctly. But I was expecting 99%, I think.
Sorry, next.
This is her CCT abdomen, which was done before presenting to us. CCT abdomen was most probably ordered by surgical oncology department to look for the hepatobiliary malignancy, suggestive of carcinoma gallbladder in previous ultrasound report. Here we can see the hypodensity in gallbladder fossa, and in other slide this hypoechoic border, and in center hyperdense material, and in other in progressive slide this is a hyperdense core with peripheral hypodense, and this is also intrahepatic biliary radicals not dilated as we can see, and there is minimal fluid collection. Here we can see in hepatorenal pouch.
So had the patient come to you first, would you have done this CT or you would have done something else after having the ultrasound, the clinical?
We will go for sir upper GI endoscopy to look
No,
for
no. Imaging, I am saying.
Imaging.
After endoscopy.
Yes, sir. CCT, triple phase CT scan, we can consider.
So you would like to do a triple phase CT in this situation. So there is something hyperdense content being seen inside the gallbladder lumen, probably blood in the gallbladder lumen. This is what I can make out of it.
We can enter angiography protocol, triple phase and CCT abdomen under angiographic protocol to look for source of bleeding in this case.
Okay. Go ahead
Next.
with rest of the investigators.
Sir, this is the report of CCT abdomen. Gallbladder distended with intraluminal sludge and irregular endophatic soft tissue attenuation, lesion of approximate size 4.3 by 3 centimeter in fundus. Could be tumefactive sludge or mass. Mild pericholecystic fluid is also noted. Wall thickness is normal. Liver enlarged in size, measuring 17 centimeter craniocaudally and mid-clavicular line, and shows normal tissue attenuation. Portal and hepatic vein mild prominent, mild ascites, and bilateral minimal pleural effusion.
So,
on the day of presentation, upper GI endoscopy was done, which was suggestive of normal esophagus. Stomach was also normal. First part of duodenum was normal, no evidence of ulcer. And in duodenum second part, altered blood was present with active oozing of fresh blood seen from papilla.
Next.
I have images. So this is fresh blood oozing from papilla. Side view endoscopy was done on the same day. Blood clots with oozing seen from papilla. On washing away, papilla revealed active oozing of blood mixed with fluid with normal appearing papilla without any evidence of ulcer or mass. And on the same day, ERCP was planned in view of tumoral bleed with hemophilia or other cause of hemophilia. Selective CBD cannulation done using guide wire. Cholangiogram suggestive of dilated CBD and intrahepatic biliary radicals. However, no filling defect identified in cholangiogram. Unfortunately, I don't have images of cholangiogram. Balloon sweeping was done with retrieval of few blood clots and 2 drain French state plastic stent placed inside bile.
Such a patient, if it comes to you still again, would you go ahead with ERCP immediately after these findings at side wing endoscopy? Would you like to do a CT angio first and then decide about doing an ERCP, or you will still do an ERCP ahead straight away? The patient was not having cholangitis. The patient was not having cholangitis.
Yes, sir.
The patient was having GI bleed.
Yes, sir.
What would you say?
Sir, if patient is hemodynamically stable, and then we can go for endoscopic intervention, or Otherwise, if patient is not hemodynamically stable, patient is in shock, then we can go for emergency angiography and interventional radiological procedure to coiling.
No, no. But endoscopic intervention will not be for stopping bleeding, no? Even
Yes.
if we are suspecting hemophilia very strongly,
Yes, sir.
endoscopic intervention will just reduce the bilirubin, treat cholangitis.
Yes, sir.
Yes, sir.
Yes, sir.
Patient was having
It was the-
cholangitis, sir. On
Yes, sir.
24th, patient
Count
was also
was
having cholangitis.
persistently rising, as we can see in previous slide. Count was 22,000. So the motive of ERCP was not to reduce or stop the bleeding. The motive of ERCP was to clear bile duct. So blood clot was retrieved. So blood clot most probably obstructing CVD and cause of cholangitis.
Dr. Mayank.
Yes, sir.
Dr. Mayank, what is the role of multiple plastic stent in case of hemophilia?
Sir, if bleeding source is inside common bile duct, then we can achieve tamponade effect by introducing multiple plastic stent, or sir, fully covered self-expanding metal stent can also be introduced to achieve tamponade effect.
Okay.
So sir, in this case, sir, two-state plastic stent placed for with motive to produce tamponade effect. And if a tumoral bleed was there, then tumoral to stop bleed. Sir, patient was admitted with us and intensively monitored, and hemoglobin was sent 12 hourly with drop of hemoglobin by 3 point on after 12 hours.
Sir, in English, where are you intending to produce this tamponade? The
Kindly go to previous
is
slide.
from
Kindly go to previous slide, please.
stenting with an intention to produce tamponade.
Yes, sir. Sorry, sir, you are not.
Where are we trying to produce? Where are we trying to produce this tamponade? Tamponade will be within the bile duct only.
Yes, sir, within the bile duct only.
And hemophilia, if it is occurring due to a malignancy, it would be somewhere from outside.
Yes, sir, from proximal
From
source.
the adjacent arteries, somewhere.
Yes, sir. Then
Anyway,
it would
go ahead.
help. And it would not help.
Okay, go ahead.
Poll question number 5. Kindly run the poll, please. Angiography can detect active bleeding when bleeding rate is as low as 0.1 to 0.2 ml per minute, 0.4 to 0.5 ml per minute, greater than less than 0.4 ml per minute, greater than 1 ml per minute. So 51% have answered 0.4 to 0.5 ml per minute, and that is the correct answer. So almost half of the audience have answered correctly.
Okay, next. Next.
Just to remind, we have another 15 minutes for discussion. So
Okay.
She was, as I told, she was admitted with us and monitored. Her hemoglobin was dropped by 3 grams per deciliter after doing ERCP. So it signifies her persistent bleed. In view of persistent bleed, CT angiography was done. So, sir, CT angiography, there is the
video.
Yes, sir, video. Here we can see no leak of contrast in hepatic parenchyma. Here we can see pneumobilia after ERCP, and still there is no contrast leak inside liver parenchyma. Here appears gallbladder, and inside gallbladder, here is the possibility of dot-like structure pseudoaneurysm, and there is extravasation of blood. I mean, repeating the video. Here we can see
Right.
extravasation of blood.
Okay. So what next you did actually?
Sir, we can do, acute cholecystectomy, since we can do cholecystectomy in the same setting. Hence, the source of bleeder identified, or otherwise, if no conservative management, coiling or embolization of vessel can be done. So, sir, after CT angiography, our final diagnosis is hemophilia with acalculous cholecystitis with bleeding from cystic artery pseudoaneurysm.
Dr. Mank, what was the cause of jaundice then?
Sir, jaundice most probably due to acute bile duct obstruction due to blood clots.
Okay.
And how do you explain your previous demonstration of, things in the gallbladder? You
Sir,
had
gallbladder
Mass.
might be distended due to accumulation of blood inside gallbladder. And pain was due to, sir, acute cholecystitis due to accumulation of blood and stretching of gallbladder.
okay.
Okay, so next, what do you do?
We have provided both options for patient party, sir, cholecystectomy and interventional radiological approach, and they opted for sir, interventional radiological approach. And sir, this is a slide showing how we manage patient. Sir, supportive care including blood transfusion with target hemoglobin of more than 8 gram per deciliter. Antibiotics were given, broad spectrum antibiotics in view of cholangitis and persistent neutropenia. ERCP with biliary stenting done to relieve sir biliary obstruction and for cholangitis, and transcatheter arterial embolization was done to stop bleeding. Sir, digital subtraction angiography was done on 25th. Sir, on angiogram, a bleeder was found from cystic artery. So coiling of a posterior branch of cystic artery was done using 2 millimeter by 2 centimeter Hyler coils. Post DSA patient was complaining of abdominal pain and fever, which was improved with symptomatic management and with antibiotics. And there was no further fall in hemoglobin post DSA. I would like to add few words regarding this abdominal pain and fever. There is possibility of post-embolization, post-coiling, post-embolization syndrome, which which is characterized by abdominal pain, fever, nausea, or vomiting. It is due to necrosis of tissue and release of damage-associated molecular pattern in circulation, and for which no specific treatment required, only analgesics and antipyretics required. And after patient was observed for next 3-4 days, and there was no fever, pain was subsided, and no further drop in hemoglobin, and discharged successfully. This is video of sir digital subtraction and
Dr. Mank,
Yes,
Dr.
sir.
Mank,
Yes, sir.
post-embolization syndrome presents after how many hours or after how many days of intervention?
Sir, it up to, sir, it can present mostly after 48 to 72 hours, but can present up to after weeks also. It, sir, depends upon the, sir, amount of tissue which is necrosed, or the artery, the diameter of artery which is embolized.
Okay.
So if
Okay,
it is
you
a
can
large
see this.
aneurysm, is there any other option which you have apart from embolization at angiography?
Sir, we can go for, sir, cholecystectomy, hence
No, angiographically, right at that time. If you discuss with your radiology colleagues, a lot of people place hepatic, would place stents. There is a
Static
possibility of
stenting can also be done, but sir,
stenting can also be done, especially in large aneurysm. If the aneurysm
large
is quite
aneurysm.
wide mouth, you
Yes,
can
sir.
place a very well place a stent in this.
Yes, sir. Across the aneurysm, we can place.
Absolutely.
If the risk of liver necrosis is more, then vascular stenting is preferred over coil embolization.
Absolutely right.
Okay,
Absolutely.
okay. So can you show this film video?
This is showing here the coil is in posterior branch of cystic artery. Here is the coil. Without any active extravasation at this point.
Mm-hmm. So how common is this cystic duct aneurysm causing as a hemophilia?
Sir, this is very rare cause of, sir, hemophilia, less than, sir, 0.5%. Sir, only few case reports are there in literature.
Mm-hmm. Because most of the time these aneurysms are more located in the right hepatic artery.
Yes, sir.
And the cystic artery is very, very uncommon.
Uncommon.
Yeah.
Have you relooked?
Dr. Abhijit, yeah, yes.
Did you have
Dr.
a
Abhijit, go ahead. Yes. Dr. Abhijit,
yeah? So I
please go ahead.
yeah, I was just asking, did you have a relook at the gallbladder? Because I'm bit concerned about the.
Necrosis of gallbladder after post-embolization.
I mean, not only that. I mean,
Yes, sir.
58 years lady presenting first time with a cystic artery aneurysm.
Yes, sir.
I'm still inclined to think if there is a primary GB pathology or not.
Yes, sir.
Yeah.
Missed mass.
Yes, sir. We kept that possibility in mind, sir. Ultrasound abdomen was done before discharge to look for any, sir, pathology, gallbladder pathology. Sir, there was nothing to show. Still, sir, hypoechoic content was there in gallbladder, sir, before discharge. So might.
If nothing was found, did you work this patient for conditions like, say, PAN and those things? Because having a aneurysm in a medium-sized artery, very uncommon, spontaneous aneurysm without any other disease.
Yes, sir.
Yeah. Yes. I agree with you, Dr. Piyush.
Dr. Mayank,
Yes, sir.
will you go for repeat CT abdomen or CT angiography to look for any evidence of primary GB pathology?
Yes, sir. Definitely, sir. After, sir, we go for, sir, repeat CT scan after few days.
Or ultrasound is sufficient to rule out that?
Sir, ultrasound if combined with Doppler probe, since primary pathology is, sir, matlab patient for which he was admitted was, sir, cystic artery aneurysm. So if we combine USG with Doppler, then can look for.
Is USG with Doppler is sufficient, or you will need CT abdomen with contrast?
So definitely CT with contrast is better.
You are changing your answers.
No, sir. CT is better, sir, to look for, sir, lymph nodes around periportal area, pericholecystic lymph node to delineate surrounding structure.
Any
Gallbladder,
role of endoscopic ultrasound?
sir. Yes, sir. We can also go for endoscopic ultrasound. Sensitivity of endoscopic ultrasound is about, sir, 80 to 90% in detecting gallbladder pathology and lymph node and pericholecystic and perihilar.
Okay,
But
since we have only 10 minutes to go, and before the Piyush Ranjan and Dr. Abhijit, they give their final take-home message, I will just, for sake of students, actually, I will just briefly tell you about how can you approach to a patient with the hemophilia. Next slide, please. So definition-wise, any bleeding from the inside to bleed tract is defined as a hemophilia. Next, please. And it can
question.
Yes. Okay.
One question. Most common cause of hemophilia is, kindly run the poll. It is malignant, traumatic, iatrogenic, or inflammatory. Most common cause of hemophilia. So around 70% have given a right answer, that is iatrogenic. Okay, go ahead, please.
Okay. So next, please. This. Okay. So as he has already written, iatrogenic remains one of the most common. And these are the three actually important studies which have been published. You see, if you see very interestingly, the study which has been published in 70s, actually late 70s, where they found the tumorigenic was the commonest one. And then later on, as we started doing more of advanced procedure like PTBD, PTCD, like tapes and liver biopsy, then definitely you will find that there is a more of actually iatrogenic. So these the three study is showing the same thing, distribution. So now it is the iatrogenic which remains the one of the commonest region for the hemophilia, followed by tuberogenic, inflammatory, vascular, and neoplastic, as we have discussed earlier. Next, please.
This is
So
second
we
last
have another
question. Kindly run the poll, please. Quincke's triad comprise of all except Quincke's triad: abdominal pain, fever, jaundice, upper GI bleed. All except.
Yes.
So quincke steroid comprises of pain, jaundice, and upper GI bleed. Fever is not a component of
Not
quincke steroid.
always a component of that.
83% have answered correctly. So
Yeah.
can we go
Next,
ahead, please?
Next, please. Next. So clinical presentation, as you have already tried, is one of the, but it is seen in hardly actually 25 to 30% of the patient. So it is not the only classically sign which you should look for, but a classical presentation of hemophilia, quickly tried if you have, you are lucky. But the presentation of the all three together is seen in 20 to 35% only. But typically hemophilia can present as a hematomesis, melena, or sometimes hematococci if it is a very torrential, with or without cholera, or depending on the rate of the bleeding and anatomical factors. Next, please. So diagnosis can be simply made by imaging, which can be highly helpful for making the initial diagnosis and guiding the therapeutic options. Though findings may be non-specific, prompting a need for clinical suspicion and careful correlation. So always actually once you see patient with the actually hemophilia, many times what you require is a high index of suspicion. So because many times it may be difficult actually to make out the diagnosis as a first instance, and you may require some specific investigation for that. Upper GI endoscopy with the direct visualization, blood or clot emerging from the bleed tract eventually confirm the diagnosis, and then you have to further find the specific investigation to find out what is the source actually. Next, please. And so we have a battery of tests available with us: ultrasound with the color Doppler, upper GI endoscopy, CT, angiography, and US or ERCP related procedure, or MRCP. Next, please.
So this is the last poll question number 8. Kindly run the poll, please. Management of hemophilia includes all except ERCP, transcatheter arterial embolization, US guided coil embolization, surgical management. All except. Kindly listen carefully. All except. I think
next.
Answer was wrong. It is a US guided coil embolization. Only 20 to 30% have given correct answer.
Okay. Next, please. Next. So finally, actually, if you have a patient of the next. So finally, if you have a patient with the hemophilia, how you should have, this is the algorithm actually you should follow. First, you look for whether the patient is hemodynamically stable or not. If the patient is hemodynamically stable, you can go ahead with the upper GI endoscopy. And if required, you can do the ERCP at the same sitting. And then you can attempt the endoscopic therapy by putting the stent or whatever way you want. And if you achieve the homeostasis, then there is no any surgical intervention required and patient is discharged. But if the patient is still stable, you can have other option, like you can go ahead with the CT scan angiography. You look for the vascular complication if they detected. If there is no detection, you simply do the endoscopic therapy. But if they are detected, then you go for the other treatment. And if the patient is unstable hemodynamically, then directly you can go ahead with the angiography and you can do the coil embolization for the arrest of the bleeding. And finally, if everything fails, then of course the surgery remains the answer. Now I will request actually our two moderator colleague, Dr. Abhijit and Dr. Piyush Ranjan, to give their take-home message or give their final comments for our students.
Oh, great. It was a great experience, let me tell you. Thanks to Professor Dikshit always, Dr. Piyush, my co-moderator here, and particularly the DNB students who must be listening to this, and Indian society. So I would suggest, most importantly, that while this case turned out to be hemophilia, let's take this as a theoretical knowledge that this can happen. This is really something like a footnote of Balian love. Okay. So while we start discussing the case, I emphasize again that we should widen our horizon, and that's my plea to my DM students. In examinations, we always see whether we like it or not. Finally, you know the diagnosis, and you start by knowing the diagnosis and end up in disaster. So my plea for the last 15 years, 20 years, which I've been presenting to all my students is, don't look at the diagnosis when you are approaching a clinical case. Think this, and I'm telling you, no examiner, whoever wants to know whether you can hit the diagnosis or not. Everybody wants to know how you analyze the case. So your ability to analyze the case expands and become very precise only when you think why this is not this. So always think why this is not this, what all else it can be. So do that. I was very happy to see both Nilesh and Mayank doing the job. And thank you. So that was all that I had, and I enjoyed it through and through. Let me tell you.
Okay. Dr. Piyush?
We thank you for providing with such an interesting case. And I fully agree with what Dr. Abhijit said. He made both of you think by posing challenges. You should always keep a broad-based diagnosis. So that is the first principle. And in this particular situation, it turned out to be hemophilia. Nobody could have made this diagnosis at the end of history or even examination. So be as broad as possible so that you don't miss. So start with the symptoms, put the chronology of symptoms very correctly. This patient started with GI bleed, jaundice developed later. So it cannot be primarily a problem with extrahepatic biliary obstruction. Something else is going on. Bleeding started first. That is what. So always be open, keep a lot of possibilities, always write down points in favor, points against what your diagnosis is. You let yourself get your answers. So thank you once again to both of you and all the best.
Okay, thank you, Dr. Abhijit and Dr. Piyush Arjan for moderating this session. And from the Department of Gastroenterology also, I want to profusely thank actually the Indian Society of Gastroenterology for Dr. Govind Makharia and his team for providing this opportunity so that our student can get analysis and they have a good interaction in presenting the case. I think everybody must have enjoyed. Thank you very much.
Thank you all.
Thank you, sir. Thank you. So I'd on behalf of the Indian Society of Gastroenterology, I'd like to close the session. We'll meet you next week for another session of ISD Masterclass 2. So thank you to all the panelists, especially to Dr. Dixit sir from BHU for giving us the case, and also to the students who presented it really well. Thanks to Dr. Piyush Ranjan sir and also to Abhijit sir for taking the case beautifully, having an excellent clinical discussion for a case that, although it was odd, but the presentation overall, the discussion was immaculate. Thank you so much, sir. Thank you so much.
Thank you. Thank you, sir. Okay.